Hello, welcome to Fertility Fact or Fiction, the show where we review an important topic every week and then answer all of your questions live. It is great to have you guys back and be back with you. Thank you for joining us tonight. As usual, we'll give you a couple minutes to jump on board, grab something to eat or drink, and pull up a chair and ask us your questions. We're here to help you through your fertility journey and make it a more effective and successful journey for you. The topic tonight is going to be whether or not donor egg recipients benefit from having their embryos tested with pre-implantation genetic testing to see if this actually makes things better or worse, or no change at all. It's an expensive sort of process to do Pgta. And the question that we have, and I'll go into quite a bit of detail with you, is whether or not this actually helps our patients. And it's typically, various groups of patients that require donor eggs, and we get a lot of questions, especially from some of our clients that have looked at other centers. So welcome to the show, and we're going to have a great topic to review for you tonight. So the topic tonight, as I mentioned, is donor eggs. And if you're using donor eggs, should you do pre-implantation genetic testing? So I want to go back a little bit to the history of genetic testing for embryos. Way back in the beginning, they first started with just doing pre-implantation genetic testing for embryos on day 3. And very quickly they realized that by removing one whole, cell from a developing embryo, that this was quite damaging to embryos. So then they developed the idea of biopsying the trophectoderm, which is the tissue that becomes the placenta later on, around day 5, or sometimes on day 6. And so the idea behind this was you wait till the embryo gets to blastocyst stage. Some people on day 3 and some people on day 5 were laser hatching the embryo. So you zap the embryo with the laser, give it a little hole, and you do it right where the trophectoderm, which is the tissue that will later become the placenta, is developing. Why? Because no one wanted to zap the part that's becoming the baby. We don't know what the impact of that will be when it's multiple cells, but they felt it was probably safe to take a piece of placenta because placenta is pretty resilient. So they wait till the tissue that is inside the embryo starts to extrude through that hole, and you get this little ballooned out part of the embryo. And that part is the part that they take the laser again, and they actually kind of trim off a piece of that tissue. That tissue then gets sent for processing and analysis, and the lab can tell you if you have a genetically normal trophectoderm or not. Now, the congruence between the trophectoderm and the embryo is fairly high, but it's not 100%, so there can be errors. And in particular, I'm sure many of you have heard about the whole topic of mosaic embryos, where some of the cells are normal, some of them are not in the trophectoderm, and does that impact the actual success rate of the whole process? And can you get a normal embryo from a mosaic reading, and can you have a normal child from that? And the answer, in short, for that part of it is yes, you can. So the idea was, let's see if we can detect which embryos are clearly going to be abnormal. If we start dropping off those embryos and only take the normal ones, we should be able to improve your chances. So that's kind of the history behind this. Now, there is a recent article that has shown that doing the embryo on biopsy on day 3 is not as good as doing the embryo biopsy on day 5, and that maybe we should wait till the embryos are further advanced before we laser hatch them. And there are other previous articles which have also suggested that you may be damaging the embryos a little bit by doing these biopsies, and on top of that, that not only you may not be improving the success rates, sometimes you may even be compromising them. There is a study that we reviewed on the show probably about 2 years ago now called the STAR trial, STAR, where they had kind of a multinational, multi-center study, randomized controlled trial, comparing doing Pgta in patients that were going through IVF, and they explored it based on age of the people that were receiving the eggs. Now, they weren't looking at egg donors. These were all autologous cycles. And in that study, they demonstrated that there was no benefit. And in fact, even further into it, other people were reanalyzing it, saying it was even worse than the authors were reporting it to be, and they had already said it didn't help. Some people were saying that it was actually potentially even harmful and that there was really absolutely no benefit to doing it. So the reason this subject has become kind of more important for me personally on the donor side of things was we get a lot of European clients who are needing egg donors. Oftentimes they're either single or couples of gay men. And then we have our own couples here where the woman has tried several times and it hasn't worked. Or again, our same-sex male couples or single male individuals here that need an egg donor and are always being told by some of the other centers or other exploration that they've done that they need to do Pgta. So the question for me was, well, we don't recommend that to them. And is there evidence to support the fact that we don't recommend it? And I always knew there was, but we hadn't reviewed it on the show. So I thought I'd bring it to your attention, because if you're looking at an egg donor cycle and you're being told you need to do Pgta, you should be aware of whether or not you need it. So this article is from 2020, October 15th, so just about 6-7 months ago. And it's called Donor Oocyte Recipients Do Not Benefit from Preimplantation Genetic Testing for Aneuploidy to Improve Pregnancy Outcomes. So the fact or fiction is in the title this time. So essentially what they did here, and we'll go to figure 1 if you can pull that up with the little people. They commented on the fact that right now donor egg cycles are representing a huge number of cycles. 22,000 donor egg cycles were done in the US in 2016, and that represented 9% of all cycles done there. So it's a really growing, very large part of the IVF world or sphere. So essentially what they wanted to do was look at using frozen eggs, which is admittedly different from fresh, but nevertheless still a valid experiment. And they had a really great model for it. So they took the donor eggs and they took 12 from each donor and they split it between the two groups, with one group being the group where they received the Pgta, representing the 262 women, and the other group being the group that did not get Pgta, which was 1,029 women. So all told, there were 1,291 cycles. Essentially, they were looking at this in the sense of, let's take the same population of eggs, split it between two groups, do Pgta on some, don't do Pgta on the others, and then let's compare them. So this is a really great way to analyze this. Admittedly, it was not a randomized controlled trial. This is a retrospective paired cohort where they matched the people that received eggs from the same donor and then compared them within those two groups. So the patients going through the donor egg cycles went through a pretty standard protocol. The eggs were frozen first, and then people would select them. And they obviously controlled for the confounding factors like age and BMI and all of these things. So these were all really important to make sure that you've got comparable groups. So what they found, the age of the patients was relatively the same, average around 42 years of age. The donor's age was about 25 and a bit. And it was all pretty much kind of the same, and there were no real significant differences in any of their other characteristics. The one interesting thing from this that they did go into was that in the Pgta group, most people tended to just get one embryo. There was a small number that had more than one. In the non-Pgta group, there was a statistically significant higher number of people getting more than one embryo, so 2 or more. And that's really important because obviously the more embryos you put in, possibly the higher the chances are going to be. But again, even if you look at national guidelines, if they're not Pgta tested, some people will allow you, or some guidelines do suggest putting in more embryos because you know some of them will be abnormal. Okay, so what did they end up with? Well, on average, 2.9 embryos were frozen or available per couple that went through this. In total, 43% of the embryos were euploid, meaning genetically normal, and 12.7% of the patients had no usable embryos whatsoever. So you can see this on figure 2 with this little bar graph. And the bar graph shows that about 43%, like I said, had all of the embryos be normal. And way out on the other side, about 12% had no embryos that were normal, almost 13%. In between all of that, the average rate, about 87.3% of patients had at least one genetically normal embryo, which was good. And there was quite a bit of variation, they report, between the centers that they did this in, because they had, I think, 47 different places that contributed to the study. But overall, they said that 75% to 78.6% were demonstrating that there were normal embryos present, and giving you a very good sort of overall chance that there was something reasonable there. Okay, so we're going to go to figure 3. So this is the difference in live births, and in the red it's all of the number of embryo transfers, and the blue is the first embryo transfer. So you can see that between the Pgta group, which is the first bar, and the no Pgta group, there is no statistically significant difference on the first or during all transfer cycles for the outcomes. So in other words, doing Pgta offered no benefit because it did not improve your chances of a successful live birth. If anything, it's even a lower number, but that is not statistically significant. So there was no difference in this study. Now, could it be that because they transferred in more embryos, they got a better result? It is possible, and you would expect that to be a problem if they were ending up with a higher number of twins. And they did have a little bit higher rate in that sense. So it was 3.4% in the Pgta group, and it was 9.8% in the non-Pgta group. So yes, they were seeing a little bit of a higher number, but again, if you're doing that reasonable sort of distribution of the number of embryos you're putting in there, they're not seeing a benefit here. It is cheating a little bit though. The best study would have been single embryo transfer, so that you really could tell the differences. The other part that they looked at was in figure 4. So if we flip over to figure 4, again in the blue you've got the first embryo transfer cycle, in the red you've got all of them. And here they looked at the pregnancy loss defined as a biochemical and clinical pregnancy loss together, or after the first transfer cycle within the same recipient. So again, in the Pgta group, they saw a norm, like the same number. There was no statistically significant difference compared to the Pgta, non-Pgta group. So they got the exact same results. Now you will see a little bit of a difference in the groups there, but they were again not statistically significantly different. When they looked at all the transfer cycles, a little bit higher, but it's still the same thing, and again there was no statistically significant difference. So they essentially concluded in their study that there was no difference in the outcomes of these patients that were getting Pgta. So for those of you that are looking at doing an egg donor cycle and you're being told that you have to do Pgta, there is certainly no current evidence that supports the idea that you're going to get a better outcome from this. Now granted, it's unusual here for us to ever put in 2 donor egg derived embryos into anybody, because we get very, very high success rates with just 1. But I don't think we would get any significant benefit from putting in embryos that were tested with Pgta. My heart does go out to those of you who have had a donor egg cycle and have ended up with genetically abnormal embryos. That is challenging emotionally, psychologically, and financially, because now you have to go through the whole process again potentially. And if you're using a surrogate, even more so. However, the rates are so low using a young donor, as you could see from this, that the reality is it's unlikely you're going to end up with genetically abnormal embryos. The majority of patients have all of their embryos be normal, and the vast majority have at least 1. So is it really going to benefit you to go through the Pgta when it could potentially be detrimental? Certainly not. There is no advantage to doing so, and there's certainly no evidence to support that approach to things. So essentially, is it a fact or a fiction that you need Pgta for donor embryos? It appears to be a fiction. You do not need donor or Pgta when you're using donor eggs as the source of your embryo creation, because it does not appear to be a benefit. Now again, we probably need a better done study where they're comparing apples to apples, which would be single embryo transfer and single embryo transfer. And that doesn't exist yet, but I'm sure someone's working on it, and hopefully we'll be able to bring that to you soon. So thank you for joining us for Fertility Fact or Fiction. We are going to take your questions live now, and just to kind of give you a little promo for next week we're actually going to just have questions on the show. We're going to jump right into it. So for those of you that are used to jumping on halfway through, if you want to get your questions answered, jump on early. We're not going to review an article. Lots of you have been asking for more time to answer the questions, so I thought we'll skip an article next week and just go right into answering questions from people. So hopefully you'll join us. I'll remind everyone a couple more times during this program, and we'll hopefully see you next week as well. So we're going to take your questions now, and I'm sure Tarek has many.
I do have many.
All right, fire away.
Now there were some questions related to the
study.
The study. Yeah.
Okay, sure.
So okay, based on this study, would you not recommend doing Pgta testing on non-donor embryos? I'm 40 and have already had a miscarriage from a natural pregnancy last year due to chromosome abnormality. I'd like to do IVF now and wonder if Pgta would harm embryos. Yeah, so when you're 40 or even over 38, we do recommend that you do Pgta. And the reason for that is once you're 40, the ratio changes dramatically, and you can find out very quickly that probably somewhere between 2/3 to 3/4 of your embryos, maybe even more, 80%, are going to be genetically not normal. So you make, let's say, 5 embryos, the chances are that 4 of them will be abnormal and 1 will be okay. So in that scenario, you benefit from doing the Pgta because you isolate which embryo is going to be useful for you. And so in older patients, there is some data, especially those that have suffered miscarriages, that it can be beneficial. As well, there is data for the donors that shows that from a cost-benefit analysis, it also is not helpful. So again, it's vastly different. When you're talking about donor eggs, you're talking about maybe 1 out of 5 being abnormal. But when you're 40 and you're doing IVF, you're talking about 1 out of 5 being normal. So in the 40-year-old, it makes sense to do it. But in the patient that's got, most of the embryos, 80% of the embryos being genetically normal, it doesn't make sense to do it because you're checking 4 embryos to find 1, or maybe 5 embryos to find 1 that's abnormal. Your chances are so good with just picking any embryo that it makes much more sense not to do it. And again, there is a cost-benefit study that showed that and supported that as well. But if you're over 38, you definitely want to consider doing Pgt, and we recommend that to all of our patients that are over 38. Okay.
Or if they've had a complex history. Yeah.
We'll go from the Instagram. One from the gram. So related to COVID.
Okay.
Does the Pfizer COVID vaccine affect the menstrual period in any way?
Abso-freaking-lutely not. I mean, that is the most ludicrous claim humanly possible. There is no association between the vaccine and any kind of hormonal change or shift in your menstruation. Sure, if you get a raging fever and you have a big immune response to it, you may alter the, timing of one period, but it's going to go away after one period. Otherwise, absolutely not. And apparently someone on some social media platform somewhere said that not only will it mess up your period, but if you've been vaccinated and you're around other women, it'll somehow mess up their period. The vaccine is not capable of doing that. If everybody understood the biology of how it works, you would understand that it has absolutely no way whatsoever of doing that. The process is that a little piece of RNA goes inside your cell. It lands on something called a ribosome. Ribosomes are these little spherical things inside your cell where they grab on to the RNA and they use it as a template to create protein. The protein it's producing is a small fragment of the spike protein from the coronavirus. It's inactive, it has no bodily function, it can't do anything inside you. Once that comes out of your cell, because your cell gets rid of it, your body mounts an immune response to it immediately, recognizing that it's not there. So those little bits of protein are gone before they can do anything anyways, because your body sees it and says, this doesn't belong here, let's get rid of it. So you mount an immune response. What have you now done? You've created a scenario where the mRNA has degraded, so there's no mRNA left, because it degrades very quickly. You've got none of the protein left because it's all being bound up by what your body has done to get rid of it. And you are now protected against coronavirus because the antibodies that are looking for more little bits of the protein you were producing are running around trying to find the same thing. And that same thing is coronavirus, which is exactly how it protects you. So if anybody on the planet can explain to me how that's going to alter your menstrual cycle, your hormones, your pregnancy, anything like that, I'd love to hear it. But the reality is it can't. It biologically cannot happen. You or your baby would have to express coronavirus spike protein somewhere inside you in order for that to be a problem. Nobody does, or else you already would have been immune to it, and therefore it's impossible for this to affect you. So no, absolutely it cannot affect your menstrual cycle whatsoever.
All right, from YouTube.
Yeah, I love YouTube. We love YouTube. You don't have to fight on YouTube for followers like you do on Instagram. Yeah, fire away.
Hi, Dr. V. Love your show.
Oh, thank you.
Age 40, AMH.5, follicle count 7.
Okay.
Is it possible for me to have 2 kids with my own eggs? How many rounds of IVF would I need?
So you should watch our IVF embryo math video on YouTube, because that's a great video to answer that question. If you wanted 1 kid, it takes about 2 or 3 tries. If you want 2, you probably are looking at doing double that. So it all has to do with how many eggs you produce, how many they fertilize, how many make it to blastocyst, how many are genetically normal, and then how many genetically normal embryos you need to achieve a success. So if you watch the video, it explains all of that, but realistically you're looking at 3 tries probably just for 1 baby. And if your AMH is kind of lower like that, it does pose some challenges. So is it possible? 100% it's possible. But is it a guarantee? No, it can be a difficult battle sometimes.
Facebook.
Sure.
Hello, Dr. Victory. Thanks for answering our questions. I'm curious about taking Provera to induce a period. How long should you be on the medication to induce a period? And can you have several weeks of it? Any long-term side effects?
You should only be on it for 10 days. If you take it for several weeks, you're thinning out your lining to the point where you won't get a period when you stop it. So in your natural menstrual cycle, what happens at the start is your progesterone's very low, your estrogen starts to climb. When it gets to a certain point, your brain recognizes there's enough estrogen because your follicle is growing, so it sends out the signal to release the egg. When you release the egg, the little area that your egg was in becomes a cyst called a corpus luteum, and that's what produces the progesterone, at least until you have a pregnancy in there. So the corpus luteum produces progesterone for several days. It goes on, usually about 10, 12 days. And then if you're not pregnant, the progesterone level falls as that corpus luteum starts to die off. And as the progesterone level falls, your lining becomes unstable. The blood vessels in your uterus begin to clamp shut. You start to shed the lining. So if you stay on progesterone for a long time, what's happening is you're thinning out your lining slowly to the point where you're not going to have a bleed, or it'd be really like a abnormal spotty kind of bleed. So is it safe to be on it? I mean, it's not great to be on progesterone forever, but it's not going to harm you for a couple of weeks, but it's not going to let you have a period. The whole point of progesterone is to be present and then be absent like it is naturally. So we call that a progesterone withdrawal test. For example, in polycystic ovarian syndrome, if you have PCO, we give you progesterone for 10 days, you stop it, you should get a period a few days later. So that's the natural kind of pattern because that's mimicking what your body normally does.
How long until I should be concerned not getting my period back postpartum? History of PCOS.
So if you're breastfeeding indefinite, if you are not breastfeeding and you've gone like 3 to 6 months without a period, you need to do something to be regular. We say this on every single show. I'm going to say it again. It is not safe to not have regular periods, despite what anybody may tell you. You are increasing your risks of cancer of the uterus, possibly even cancer of the ovary and breast. So you must be regular. You must be regular. So make sure that you are ovulating on a regular basis or that you're on birth control. But it is not okay to go months at a time without having a period regularly.
Hi, Dr. Victory. I'm getting an FAT with you.
Oh, awesome.
And I was wondering if I have a limited number of eggs retrieved embryos, would a fresh transfer be considered?
Yeah, so in our natural cycles that we do, or like a mini stim where your estrogen level isn't going very high, if we only get 1 or 2 embryos, we will sometimes consider doing a fresh transfer. And in fact, in those cases, sometimes we'll even do it on day 3. The only issues with that is that you need to make sure that your progesterone doesn't rise prematurely, because that's like taking birth control. And the other thing that we need to make sure is you're not a patient with special needs such as Pgt, which cannot be done fresh, or that you have endometriosis where we need to suppress you first. So if the shoe fits, so to speak, yes, we can do a fresh transfer. But if you don't have those qualifications, then we would do a frozen for sure. So if you have endo, you need a frozen transfer. If you have very high estrogen levels or your progesterone level goes up early, you need a frozen transfer. So we individualize. I was just writing this to a European client who was telling me that in the UK, they kind of get the same thing no matter who they are or what's wrong. So you can't practice fertility like that. It's not cookie cutter medicine. I always say we're not baking cookies here, we're making babies. So you've got to individualize for each patient, and that's what we really try very hard to do.
Hi, Dr. V. What determines how much estrogen, if any, you will use in a patient's FET protocol?
So we want to try and minimize the amount of estrogen because there are more and more studies coming out showing that estrogen is probably not good. That's one of the reasons why the frozen embryo transfers are now favored over the fresh. It's because you can use less estrogen or at least be exposed to less estrogen. With our protocol, the way we've run it now, where we integrated letrozole into the protocol, we actually don't need to use very much estrogen at all. In fact, recently I've instructed our team not to start estrogen unless we need it, because it's actually fairly rare that our patients end up needing the estrogen. The letrozole does the trick for you. So we actually follow the science of what we learn on the show. So in preparation for all of the things we do for the show, we learn little bits each time and we integrate that into what we do for our patients. So one of those big things was minimize estrogen and use letrozole instead. So that's what we do. So you only use the smallest amount of estrogen you need to achieve success, no more than that.
I have an appointment with you in June. How soon you'll be able to accommodate IVF with you?
Oh, well, we can accommodate it as soon as necessary. The question is, how long will it take us to do it right? So we get requests from people all over the world to help them out right away. And what I tell everybody is, if you want a rush job on IVF, I'm probably not the right guy, because I take my time to make sure I'm going to do it right. I don't rush into things just because people want to hurry. I get it. There's age, there's frustration, there's finances, there's COVID. Like, I understand. But at the same time, taking 1 month to make sure that I'm doing the absolute best job possible for you is very important to me and to you, to make sure that we are doing the right thing. Rushing into fertility is a great way to make someone rich and to make you poor, because it's probably not going to work. We get paid regardless of whether it works or not, unless you're choosing a guarantee. But you know, if you're not choosing a guarantee, you're spending money, and if it doesn't work, you're spending money again. So my goal is always to make it work from the first try, so that you don't have to spend more money than you need to. So we can get you right into IVF immediately if you have everything ready to go. But the reality is it usually takes at least about a month or two to get everybody ready, to make sure that you've optimized the sperm, you've optimized the egg quality, you've done everything holistic possible to give them the best chances in terms of egg quality, uterine lining, sperm quality, your own general well-being. Is your weight appropriate? Is your blood pressure okay? What's your diet like? Where are your stress levels? I get patients from, again, all over the world, where we facilitate helping them by letting them use Organic Conceptions, which is our online program that we use. We pay for it so that you don't have to. So there's all sorts of resources. We have our social worker, our psychologist, our nutritionist, our naturopath. We use all of these things to make sure you're getting a very holistic approach, so that this isn't just a, you know, here's another cycle of IVF. Instead, it's here's our path to success. And if you want us to walk with you on that path, by all means, we will do so. And we can kind of sprint down the path as well. But I don't love taking another path, which is the shortcut route, because you can trip and fall on that path, and that's not fun.
A question from Twitter.
From Twitter! Hey, we never get anyone on Twitter. I love it. Fire away. That's great. Hello, Twitter. And thank you for joining.
Can you actually have a HPT negative and have a positive beta?
Yeah. So you can have a negative home preg test and have a positive beta. That can happen for a variety of reasons. The test could be bad. You may have tested too early. If it's exposed or it's oxidized for too long, it may not work. Those home tests are very accurate, but they're not 100% accurate. So yeah, you can have a negative home preg test and a positive beta. Is it frequent? No. But is it possible? It's definitely possible. And tell other people on Twitter to watch.
There we go. Can
cholestasis, yeah,
during pregnancy affect the baby?
Yeah, for sure. So if you develop cholestasis in pregnancy, that automatically becomes a very high-risk pregnancy. And we typically deliver those babies at 36 weeks because the risk of stillbirth and intrapartum fetal asphyxia increases. So those are very high-risk pregnancies. And we deliver those babies early, and we watch them like a hawk. You need a weekly ultrasound, non-stress test, that kind of thing, to be extra cautious. It is a risky thing that happens, so we're very, very careful with those patients for sure. Yeah, good question.
What is the smallest amount of follicles that you have performed IVF and have had a successful pregnancy? 1.
We do natural cycle IVF all the time. So for some patients that just don't respond well to the meds, can't afford the meds, had a bad experience before, or are only producing one egg, we just go ahead. I, in fact, have one patient who is a lovely, lovely woman, both she and her husband. She was a bit older. He did not necessarily have the best sperm ever. And we did, 2 natural cycles for actually 2 different kids, and we were successful both times. So we did great, and we only had one egg. Yeah, so we do that all the time, and it works out great. Yeah. It's not, infertility is not just about numbers, guys. So like I sit here every time and I talk to you guys about percentages, and we talk about, risks, and we talk about chances and stuff like that. And everyone wants to have 100 eggs. I get it. But the reality is, I don't need 100 eggs. I need one good one, and I need one good sperm, and I need a good uterus. So, if the pieces of the puzzle are there, you can get the whole picture. If the pieces of the puzzle aren't there, well, then it's a missing piece and it doesn't work. But as long as you have the pieces you need, whether it's 10 of them or one, having 10 more of the same piece doesn't help you. You just needed the one. So that's the way you need to look at this. Don't be discouraged because you only have one egg. Does it make it more difficult? Yes, it definitely makes it more difficult. Anyone that's not telling you that is lying to you. But does it make it impossible? Absolutely not. There are loads of people that are successful with a low number of eggs. A good friend of mine, Eve Feinberg, who's in Chicago at Northwestern, one of the smartest ladies I know anywhere. Eve said to me once, she got a woman pregnant with just one egg with an FSH that was like 115 or something like that, where she was clearly menopausal, but she was able to produce one egg and they got her pregnant. So, you know, anything is possible. It's just a matter of how hard you're willing to try, how much you can afford, which has a lot to do with it, and, you know, what you want out of it and how quickly you want it. Yeah.
You previously mentioned the Pro Fertile rather than Fertile Pro supplements are recommended when wanting a fast way to improve sperm health.
Yeah.
Can you please explain the reason and is the price worth paying?
Yeah, so look, I like both, and I certainly don't promote any product over any other. So I'm not telling you which one to take. In fact, we aren't even allowed to do that. However, I actually don't promote one over the other. But here's what I can tell you. They're both excellent products. In my experience, they both work fairly well. The biggest difference is that Fertile Pro, which is made in Canada, has a bunch of different bottles that you need in order to get kind of the same effect. And there are no clinical studies supporting the fact that it is beneficial. With Pro Fertile, they actually did clinical studies and demonstrated that there was an improvement in both sperm quality and the DNA fragmentation. And they actually have approval from Health Canada for the indication of improving sperm. I'm not aware of any company anywhere that has done that before. So is it more expensive? Yes, it's about $100 more. Is it worth it? Well, that's a judgment call. I can't answer that for you. You have to. Excuse me, but what I can tell you is that it works well and they have clinical data to support it. Does Pro Fertile work well? I mean, Fertile Pro work well? Yeah, in our experience, it works quite well as well. So you're welcome to try either one, and don't feel any pressure from anybody to use this one or that one or anything like that. I'm open book about it. Choose whichever one you want and use whichever one you want. Just remember that one has data behind it, the other one does not. That one's more expensive, the other one's a little bit cheaper. We need more Twitter questions.
She has a follow-up.
Ask the follow-up. Let's spoil Twitter.
She does have a follow-up.
We never get Twitter questions.
Oh, it's an interesting question.
Okay.
I'm thinking of going to you for my next IVF.
Awesome.
I'm with Nahal Fertility Clinic and 2 IVFs and nothing.
Okay.
I think it's just a comment, actually.
Oh, it's just a comment. Well, I used to be the medical director at the Nahal Fertility Program. We would be more than happy to help you out, and I would love to hear how we can facilitate assisting you. Let us know if we can be of service. We are happy to be of service. Just contact info@drvictory.com or have your family doctor send a fax over, and they will set everything up for you as a referral. So yeah, we'd be more than happy to help you out.
Hello, Dr. Victory. My question is, I had 2 follicles. One was 18 millimeters and one was 15 millimeters on day 15.
Oh.
I was triggered on day 16. What is ovulation guaranteed with the dual trigger?
So first of all, that's a pretty long cycle, but acceptable. If it takes that long, it takes that long. There's no guarantee of ovulation. We always used to be taught in training that the only guarantee of ovulation was pregnancy, or the only proof of ovulation was pregnancy. So there's no guarantee with any kind of trigger, but the incidence of pregnancy is higher when you use a double trigger because you're getting a more positive result in terms of chances that you are going to release. It's probably up around 99%, maybe even higher. And we have a video on that. Gosh, that was a while ago we did the double trigger. We have a dual trigger video, so it's in YouTube. Go back and check that out. But it is available for you to have a look at. And it does show that the results are better with the double trigger than with the single trigger. My only concern for you is you said you waited till day 16. That's a very long wait. So Ideally, you don't wait that long. You want to really trigger it the latest by 11 or 12 days of stimulation. Now, granted, if you started on day 3, 11 or 12 days of stim, you're getting close to that day 15, 16, but you don't want to go that far. You want to try and trigger it the very, very latest by day 12. There are some cases where you have to go longer because the eggs just aren't growing, but it does compromise the chances, and we actually have a video on that too.
From Instagram.
Instagram.
Who would benefit from estrogen and testosterone priming versus birth control pill?
Okay, so no one who benefits from testosterone or estrogen priming should be doing birth control pill. Birth control pill either has no effect or a suppressive effect, so it can kind of shut down the ovaries sometimes. Testosterone and estrogen priming are designed to actually help activate the ovaries and kind of fluff them up a little bit to give them a better chance of making more eggs. So if you have weak ovaries, you will benefit from estrogen, testosterone. If you have super strong ovaries like PCO, they benefit from taking the pill. If you're in the middle, you're probably okay on the pill or nothing. You probably don't need testosterone, estrogen priming if you're in the middle. So testosterone, estrogen for weak ovaries, the pill for kind of everybody else. But you should never be on the birth control pill if your ovaries are weaker. Good question. Hopefully no one told you to be on the pill if you have weak ovaries.
COVID question.
I love the COVID questions.
You got a bunch of them scattered throughout.
Oh, really? Yeah, fire away. Everybody's worried about COVID, so yeah, fire away. I'm good with the COVID questions.
Are you seeing an increase in FET failure in women that recently did the Pfizer-Moderna vaccine? So worried I made a mistake by getting mine.
So I ask my patients to wait 2 months. Even though the guidelines don't suggest that, it doesn't metabolically make sense to me. So we're not seeing an increase. I don't know about everybody else, but the guidelines are saying go ahead, like 3 days later, you can go ahead and do it. But we know from immunological studies that if your immune system's really active, it makes it harder to get pregnant. So, and there's a whole field dedicated to, immune reproductive concerns. My close friends, Chloe Romain and Fred Zineku out of Toronto at Tripod Fertility, that's what they specialize in, and they're fantastic at it. So if you need them, by all means, free promotion for them. Go see them. They're great people. They're very decent people, and they do a very, very good job. So that whole kind of scope and sphere of people or of process with immune function is very, very important to the ability of your embryo to implant. What happens with the COVID vaccine? Well, for the first 2 months, your body's in overdrive producing tons and tons of antibody. So your immune system is very active. Is that a good time to put in an embryo? Not in my opinion. So there's no data that supports that, but biologically it just doesn't make sense. And sometimes when there's no data, you still have to make a logical consideration. I'll give you the best example possible. There are loads of people that say bed rest is useless when you are having a weak cervix or preterm labor because it doesn't prevent preterm labor. And they've done studies that show that bed rest doesn't prevent preterm labor. The problem is, what is true bed rest and what is taking pressure off of the cervix? So many of you know that I'll take you and I'll kind of dangle you upside down, even for months if I have to prevent you from delivering early. And the rationale behind that is I'm taking pressure off your cervix. So just logically, because there's no evidence for this stuff, does it make sense to put pressure on a strained cervix? Of course it doesn't. I don't need a study to tell me that. If I'm taking gravity and pushing down on something that's already weakened, sooner or later it's going to break. So taking pressure off of that same thing will obviously let it survive longer. So not everything needs evidence to just be common sense. Would it be great if we had a study comparing it? Yes, of course. But until we do, sometimes you just have to make rational decisions. And that's, a good example of one.
That's assuming gravity exists.
Yeah, assuming the Earth is round,
That's right.
those sorts of details.
Yeah.
Yeah.
Okay. Sorry. Do you recommend any sort? This is just so.
Tarek's low on sugar now.
Do you recommend any sort of bed rest or lowered activity level post embryo transfer?
Can you eat now? It's 8:45. You can eat now. A big round of applause for Tarek, a very faithful and devout religious fellow who needs to eat. You forgot to go get your water too, man. You sure? So the answer is, what was the question? I got sidelined by you.
Bed rest.
Oh, bed rest. Yeah.
Lowered activity level post embryo.
No, so we actually looked at that, and we've reviewed that on the show probably like 2 years ago. So there is no benefit to bed rest. Now, I do recommend that you do whatever stresses you the least. Some people want to go for walks. Some people want to chill out and watch Netflix. Whatever you like, just don't do anything crazy, no extremes. Like, don't go training for a marathon the next day or, heavy duty lifting and straining. But if you're happy doing like some light work, that's great. And if you're happy resting, then rest. There's no difference in any of the studies to date.
You have so many questions. I don't know what you're going to do.
So remember, for all those of you that have lots of questions, next week's show, there is no paper at the start. We're just going to dive into your questions right away. So don't show up halfway through because you didn't care about the study. Come on in early so we can get all your questions answered. Yeah. And we got to let Tarek at least have some fluids and food. So you want me to do it and you go get your food?
Well, I'm going to answer the questions. That's what you want me to do.
No, I'm saying, do you want me to read the... No. I can read off the laptop.
No, I'm good. No.
All right. Next week, we won't have to worry about this anymore because Tarek won't be fasting.
How many weeks do you recommend a person be before to get the COVID-19 vaccine?
Okay, so ideally you get vaccinated as soon as possible. Here's what you need to understand. There is absolutely no chance that the vaccine by itself will cause a miscarriage. And there's no chance it'll cause any pregnancy complications either, unless you develop a really raging fever or get some, kind of overblown immune response to it or something like that. My dilemma with this question is, I know biologically that it is extremely unlikely to affect your chances of getting or staying pregnant. However, if something happens, every single person that got the vaccine is going to blame the vaccine. So we are telling our patients to kind of consider it for themselves and think it through. If you think that you are going to blame the vaccine, then don't get the vaccine, because then you're forever going to regret getting the vaccine. But if you realize that there's no way it could do that and you're willing to take the chance like everybody else that you have a 1 in 6 chance of having a miscarriage, regardless of whether or not you've been vaccinated, then go get vaccinated because it is safer. And if you guys missed it, there was a recent study published, I think in the American Journal of Obstetrics and Gynecology, looking at the risks of outcomes for pregnant women that were contracting COVID-19. It is horrifying. I put it up on an Instagram post. It is absolutely horrifying. 22.3-fold increase. So that is a 2,130% increase in your risk of dying. 400% increase in risk of ICU admission. I think 300 and something percent in preeclampsia rates, preterm labor. Everything was terribly, terribly off if you get COVID while you're pregnant. So protecting your pregnancy is getting the vaccine. Everybody's worried they're harming the pregnancy. You are harming the pregnancy by not getting vaccinated. So if you want to protect your child, get vaccinated. I can't make it clearer than that, can I? Yeah, straightforward. There you go.
Hi, Dr. B.
Hello.
I have what my doctor believes are 2 small endometriomas.
Yeah.
1 on each ovary.
Okay.
No blatant endometriosis symptoms ever.
Okay.
Do you think I need to do endo testing or other workup prior to FET?
Sure. Okay, so there is no such thing as endo testing. If they're telling you to do Receptiva or a BCL test or something like that, there is absolutely zero proof anywhere that this is diagnostic for endo, so don't waste your money or your time. If you want to get treated for endo, you either need laparoscopy with surgery to go in and remove the endometriomas. And yes, if you have two small ones on both ovaries, I would recommend getting rid of them while they're small because all they do is get bigger. Or you need to be on suppressive medication for 3 months minimum prior to doing the embryo transfer. So you should be on Lupron and Letrozole for 3 months before you do the embryo transfer to get your endometriosis to be as quiet as possible. Endo is overactivating your immune system. An overactive immune system, like we talked about a moment ago, is not favorable for getting pregnant. So to calm that down, you need to tone down the endo. To do that, you need to turn off your estrogen. So you need Lupron and Letrozole for that.
So no question, you need to do a COVID video.
Another COVID video?
Oh yeah. So another question related to the vaccine. Is it fine to get the COVID vaccine after retrievals while we wait for Pgt results and before FET? Example, 1 to 2 months.
Yeah, for sure. Absolutely. It's not just fine, it's ideal. Go for it. That's perfect. Great plan. I strongly encourage that plan. I love that plan. Big round of applause, thumbs up for whoever said that.
That plan.
That plan, yeah.
I've heard you say you recommend no heavy lifting after a FET.
Yeah.
I'm a nurse, which can often be a physical job.
Yep.
What do you recommend for your patients who are nurse after a FET?
I recommend a note from our front desk saying you can't lift anything heavy. So first of all, thank you for your service. It's amazing having nurses. I love my nurses. And this, by the way, for all those of you who are nurses, is Nursing Week. So, or Nurses Week, I should say. So thank you to all the nurses out there, male and female, for all of your service and dedication. We could not be who we are without you guys. And to my team of nurses, both in Sarnia and Windsor, and the former nurses I worked with at Nahal, and all the nurses at Create and IVF Canada, thank you to all of you. Nothing but respect and love for all of those of you who have tirelessly invested into this process. So I do think that it doesn't make sense to lift stuff that's heavy. So in that nursing role, we would give you a day or two off, or even a week off if you wanted it, or at least a note that says you can't lift something heavy. So yeah, I don't think that's a big problem. Just ask your doctor to give you some time, or a letter.
So many questions.
We're going to be here all night. You're going to be starving.
Yeah.
Tarek is going to be a husk by the time
I'm
we're...
just gonna keep getting the chocolate.
Get some chocolate. There's chocolate-covered almonds.
Here we go. This one's for you.
Okay.
Can you explain the birth guarantee program, costs and criteria, example age, AMH, and how many rounds?
Sure. Get some chocolate almonds. They're right there, dude. Okay, so yeah, we have live birth guarantee programs. Our live birth guarantee programs do have criteria. So depending on whether you're using a donor or a surrogate or your own eggs, there are different criteria. So no smoking, no drinking, no drug use. Your body mass index has to be normal. You cannot have failed somewhere else before, or failed an IVF cycle before. Age has to be under 40. There is a minimum number of eggs and normal embryos that have to be produced. But as long as we get what we need, which actually applies to a huge number of patients, then yeah, we're willing to put our money where our mouth is and guarantee it. We do keep some of the money. So I think it's $37.50 that we keep as an administrative fee, even if it is not successful. But if it's successful, obviously you paid a little bit more, but you had less stress. And if it's not successful, you get the vast majority of your money back.
Hello, I am on day 6 of stim. See 9 follicles, only 2 to 3 measuring at 10 millimeters. Doc says continue meds for another 2 days. I'm on 300 Gonal-F and 150 Menopur, 5 milligrams letrozole. Thoughts, age 43.
So she's day which of stim? 6 or 9?
Day 6 of stim, see 9 follicles, only 2 to 3 measuring at 10 millimeters.
You know, for a 43-year-old, that's probably pretty average. If you've only been 6 days into the stim, we've still got 5 days to go, you'll probably get at least 3 or 4 follicles that will hopefully hit the right stage. At 43, that's reasonable. I mean, keep in mind you need a lot of eggs to get one successful pregnancy. Again, I'd encourage you to watch our video called Embryo Math on YouTube. The Embryo Math video is a great video. I put together a whole research thing. I created the PowerPoint presentation to make it super easy to walk through. So check that out. It makes it very, very easy to understand. But essentially, you need a lot of eggs at 43 to get one normal embryo. So will you get a couple? You will get a couple most likely on time. Is it going to work? You probably will need several cycles of IVF to be successful to have one child. So be prepared to do multiple cycles. If you're going into an IVF cycle at 43 thinking this is a slam dunk, it's going to happen on the first try, you're not really being advised properly, or maybe you're misinterpreting what they've told you. There was a great study last year, I think it was last year, where an Israeli group analyzed what people thought their success rate was after they had been told what their success rate was. So they actually took women 43 and over and told them all that you have a 5% chance of success. And they made it very clear to the patients that the chance of success was 5%. Granted, that's probably a little low, but that's what they were told, okay? And then they let them out of the office, and on the way out, they asked them to fill out a questionnaire. And the questionnaire said, based on your discussion today, what do you think your chances of success are? And the average was 49.3%. So people thought that their chances were 10 times higher than what they were being told. You got to understand when you go into an IVF cycle at 43 that there are limited chances of success. It is not anywhere close to 50%. And you may need multiple tries before you cumulatively get that percentage high enough that it makes sense to actually, continue that far or be successful.
What are the signs of gestational diabetes?
Nothing. There is no sign of gestational diabetes. It's not like normal diabetes, type 1 diabetes, where you're thirsty or you're peeing a lot or something like that, or you go into DKA, diabetic ketoacidosis. Most of the time there is no warning sign. What causes it? It can be genetics, it can be too much weight gain, it can be too much adipose tissue. There are a variety of different things that can cause it, but the reality is that there are no symptoms. We have loads of people that have gestational diabetes, don't have a clue that they have gestational diabetes. Nothing's changed about how they feel. Yeah.
Hey, Dr. V. Just found out I'm 5 weeks pregnant after 2 miscarriages.
Congratulations.
One in December and one in March.
Okay.
Progesterone was offered to me, and I was wondering if you would recommend to start it now.
Yeah, I mean, we like to start our progesterone early, so I would start it as soon as possible. There are a couple of studies that have demonstrated that if you wait out till now, where you're at, and start progesterone, it is not beneficial. There are none that show that it's harmful, but they haven't shown that it's helpful. For us, when we're struggling with patients that have had miscarriage, we start our aspirin before they get pregnant, and we start the progesterone immediately at the right time, which is 2 days after your surge or the day after you make the baby. So that's kind of our practice here, and we're really quite strict about that with our patients. But yeah, I mean, it's not going to hurt. It's just not necessarily going to help. And that's what the studies have shown so far.
Based on this new study, would you not recommend doing Pgta on, I think we did that. Oh no, we didn't. Would you not recommend doing Pgta testing on non-donor embryos? I'm 40 and I've had already a miscarriage from a natural pregnancy last year due to chromosomal abnormality.
That was the same one.
Yeah, okay.
Yeah. So I answered that question earlier, but if you're 40, you should do Pgta. If you're in the donor range, and that study was 25.6 was average, you don't need it. If you're under 38, you really don't need it. 37, 38, borderline, over 38 for sure, but anything younger than that, there's no clinically proven benefit to doing Pgta. No study has shown a benefit, and one has actually shown potential harm.
I've heard of some doctors doing only Gonal-F for stims instead of Gonal-F plus Menipur for a standard IVF cycle. What would be the difference for either protocol?
So I'm only aware of one study that demonstrates a significant benefit, and the benefit was in increasing the percentage of genetically normal embryos by mixing the ratio of urinary to recombinant gonadotropins. There was another study I came across recently that said that you need the same thing for donors as well. So we always mix. I never do just Gonal-F. We always mix with a urinary derived product because you want some LH activity in there.
What are your thoughts on laparoscopy on someone with diminished ovarian reserve? Can there be adverse effects on egg reserve?
Only if they tear apart your ovary. So if you have diminished ovarian reserve and they're going in to take out a cyst, anticipate that your ovary is going to be weaker afterwards. So you have to weigh the risks and benefits of taking out whatever kind of cyst it is against the damage it's going to cause to your ovary. But leaving it there puts pressure on the cortex of the ovary, which also damages the ovary. So it's very much catch-22. I do all my own surgeries, so I am a fan of doing surgery in the right circumstances. Of course, I go into it knowing that I'm protecting my patient's fertility, so I'm very delicate and I'm very careful. And we do have loads and loads of patients who have actually scheduled IVF, come and do surgery with us in between, for example, an egg retrieval and a transfer, and then get pregnant in between because the surgery actually worked to clear up the problem, which often is endo. So it can be beneficial, but if they're going to tear into your ovary or you're going somewhere where they're cauterizing the cyst or something like that, or the ovary, you're going to do a huge amount of damage and very considerably alter your ovarian reserve even worse. So it depends on the surgeon and it depends on the surgery that's being done.
How beneficial do you think Omnitrope is for a 39-year-old? 2 IVF rounds, 22 eggs retrieved between cycles, 1 unsuccessful fresh transfer. My clinic refuses to allow Omnitrope at all.
So I don't even know what Omnitrope is because I think it's European. I can probably look it up. We don't use Omnitrope here, but I don't think there's any one thing out there that is hugely beneficial over another. Let's see what Omnitrope is. Omnitrope, growth hormone. Oh, well, that used to be called Sizin. So Omnitrope is not useful for IVF. They've got a randomized controlled trial that demonstrates that it is not useful. Now, you said that you had 22 eggs and you did a fresh transfer. That actually doesn't really make a lot of sense because your estrogen levels are going to be sky high. Almost for sure your progesterone levels would have been elevated. That's the wrong time to do a fresh transfer. If you have 22 eggs, you need a frozen embryo transfer for sure. So you'll probably be successful when you do a frozen embryo transfer. Omnitrope will not help you in a fresh cycle based on the most recent evidence. I think, maybe one of these, maybe next time we'll do Omnitrope, we'll do Sizin. It's the human growth hormone. So I'll review it for you guys next time because I promised next week we're going to go straight into questions. But there won't be a paper next week. We're just going to dive right into answering questions. But yeah, Sizin or human growth hormone or Omnitrope has not been proven to increase your success rate or live birth rate. There was a very well done randomized controlled trial about a year ago now that demonstrated that there was no benefit to using it.
You mentioned that there's no need to wait 2 months post second COVID vaccine dose.
Right.
What is the reason?
Because the immune reactivity to the second dose is minimal. You've already started churning out antibody levels. You only get an extra 10, maybe 15% by adding in the second dose. It's not enough to need to prevent someone from doing fertility treatment. The first one, you're really into hyperactive mode. The second one, it's like a tweak. It's a nudge. It's not anything nearly as strong.
904.
Yeah, and you're starving, man.
Just let me know.
I gotta feed you.
How do you decide which embryo to transfer for your first FET? If you don't know if you have silent endo, would you transfer the highest graded embryo first?
Well, if you're worried about endo, you should go get surgery to see if you have endo, or take an endo protocol prior to your embryo transfer. But which one do we select? Always day 5 before day 6, and then the highest graded embryo. Do we kind of downgrade our embryos before we do the first one so that if it doesn't work, we go and do surgery? Well, then you don't know if it was the embryo or laparoscopy. So I don't believe in doing it that way. Embryos are precious. You don't want to use them as pawns to figure out if something's working or not. So if you're worried about endo, go get your surgery first. There's no reason to wait. Do you want me to do the rocket thing? Because you're starving me.
You have no idea what year.
You go get food. I'll do the rocket thing and then I'll end it.
So rocket on Instagram?
Yeah, I'll rocket it on Instagram. Okay, we're going to do rocket. Go eat. I'm feeling terrible for you. Of course I should. Okay. When is cramping in the first trimester a concern? If there's bleeding, if there is leakage of fluid, if it's persistent and it's getting stronger. Since Ontario is delaying the second COVID dose, if my second dose schedule will coincide with my first trimester, should I wait to do my FET until after that second dose? No, getting the second dose in your first trimester is not a problem. I'm 39 and starting my duo-stim next month. Would it make sense to transfer 2 to 3 embryos instead of doing Pgt testing in order to save money? No, at 39, you should do Pgt testing because we want to know which of your embryos is normal versus not normal. That's really, really important for you guys. I'm taking a soft gel Weber Naturals. Oh, you know what? Let me go back for 1 second. And you also never want to transfer 3 embryos. The likelihood of ending up with triplets is there, and that's a very complicated pregnancy. I just had to put a cerclage in one of my triplet patients who wasn't IVF recently, so don't do triplet pregnancies. Don't do even double embryo transfers if you can avoid it, one at a time. So at 39, do your Pgta, make sure your embryos are normal, then go ahead and put it in. It'll also help guide what you do later in terms of decision making by knowing how many embryos you had that were normal. I'm taking a soft gel Weber Naturals 1000 IU vitamin D. Do I still need to take it with fatty foods for the vitamin to be absorbed? Or since it's soft gel, then can I take it with non-fatty food? It's always better to take fat-soluble vitamins with fatty foods. So that's probably a reasonable thing. You should be taking minimum 2,000, so take some extra. And vitamin D for some people is very hard to absorb. So the easy answer is just get your levels checked and see if you're absorbing enough. I went with an egg donor who is 23 as I am almost 40 with diminished ovarian reserve. We have male factor with poor morphology and no motility. I am very sorry. We have 1 day 6 embryo going to transfer in July. Does poor morphology, and then that ended the question. I don't know what the rest of the question was. I'm sorry. I can't read the rest of your question, so I don't know. Poor morphology can significantly impact the quality of your eggs, so that's a possibility. Does it play a part in abnormal embryos? Yes, poor morphology can lead to abnormal embryos, especially if they didn't spend the time with ICSI to get the best sperm quality. Are you worried about the unknown impact of the COVID vaccine on embryo transfers? Not at all. There is no unknown impact. It cannot impact things, at least later on. Wait the 2 months, but otherwise no. Got my vaccine, but very worried I will have failed transfers due to the vaccine's possible impact. You're not going to fail any transfers because of the vaccine's impact, I promise. You weren't kidding, man. There's a lot of questions here. We got a long night ahead of us.
I don't even know what's here.
Does endometriosis on the ovaries change the quality of the eggs? Yes, it does change the quality of the eggs. I live in Toronto, GTA. What Toronto clinics do you work at? I work at Create, and we have an affiliation with IVF Canada as well. So get in touch with us, and we will see where you want to go. I'm open to whatever you want. We have bid on 3 houses in Windsor to be closer to you for IVF treatment. All were overbid. Do you have room to rent? We're great cooks, and we'll clean the house. I know who this is from, so I'll just say L and S, I love you both. You do not need to move here to be near me. I will help you regardless. You guys are hilarious. You don't need to move to Windsor. I said this to you last week. You guys are too funny. No one's ever offered to move for me though, so I am very, very flattered. I don't think my wife and my oldest or my currently visiting mother-in-law would be into having you guys join us there. Do I recommend waiting 2 months from the date of the first shot or the second from the first? Is melatonin safe during FET? It's not just safe, you have to use it because it increases your chances significantly. We have a melatonin video. Hi there, is there any intervention needed if euthyroid, normal TSH, T4, T3, but positive thyroid antibodies? Yes, you want to tweak the thyroid to get the antibody levels lower. I am 44 years old and had 2 egg retrievals and got 22 mature eggs. How many good embryos do you think I will get at 44 years old with 22 mature eggs? Thanks, much appreciated. Okay, so if you watch the embryo math video, you'll get this. So if you're at a good center, like a really top-notch center, they'll get you 90% fertilized with ICSI. If you're at an average center, they'll probably get you around 80%, 70% fertilized with ICSI. So let's be conservative and say you get 16 or 17, for ease of math, let's use 16. 16 of them will fertilize. From your 16 that fertilized, again, if you're at a good center, 50 to 60% will turn into blastocysts. If you're at a great center, higher than that. We've had a run on our blastocysts where most of our embryos are turning into blastocysts, or our rate's very high right now. But anticipate 50%, and that's what we kept in the embryo math because that's average. So if you get 50%, then you're looking at, from your 16, you're going to get down to 8 embryos that are normal, or sorry, that are blastocysts. At the blastocyst stage at 44, somewhere between 80 to 90% of your embryos are abnormal. So you may get 1 normal embryo. That would be realistic to expect. Maybe 2 if you're really lucky, possibly none. And there's a way to calculate it, but it's super sophisticated. So anticipate, roughly speaking, anywhere from 0 to 2 maximum that would be normal. You have some there you want to ask me?
Some.
Yeah. First FET with 1 untested embryo failed to implant. Second FET with 2 untested embryos resulted in ectopic. What testing protocol would you recommend for next FET? Love the name. Hey there, Delilah. Okay, so we have a really complicated protocol, and I would need to know more about your history. So I'd never like just kind of answering these questions like this, but we have a very sophisticated protocol we've actually built based on doing this show, which works amazingly well for us. So reach out to us and I'll go through it with you. Just contact info@drvictory.com and I'll be happy to share the protocol with you. We don't hide it from anybody. It's just lengthy to go into on the show. Okay, 2 more questions, then it's 9:15, dude.
All right.
Yeah.
When would you do a fresh embryo transfer versus frozen?
Fresh, low estrogen, low progesterone, you only have 1 or 2 eggs. Otherwise frozen.
Sorry, I have a question. Can you actually, we're hoping to have a second child later this year. Should I wait to get the COVID vaccine prior to fertility treatment?
No, get your COVID vaccine. Everybody, please go get your COVID vaccines. Go get your vaccine.
What's the normal protocol for an FET? How soon after egg retrieval can I do one? I have Pcos, so higher risk of OHSS.
Yeah.
Could I likely do an FET the following cycle? And then she continues, since going off birth control, I've only gone a period by taking Provera.
Yeah.
After an egg retrieval. Would the stims cause me to have a period afterwards? Or should I be asking for Provera to take after?
No, you will get a period after the stims for sure. And we normally, with a PCO, if you're making a high number of eggs, we'd probably tell you to wait 2 months. So skip the first period, and then when you start the next one, you should probably be fine. And that should give you a very reasonable chance of success. For those of you, because we're going to go off the air in a moment, who didn't get a chance to get all your questions answered, the next show we're going straight to questions. There will not be a paper. So you're certainly welcome to save your questions and join us there. You got one killer question?
Monday,
Yeah, it'll be, is it next Monday? Did we check the schedule? It'll probably be next Monday. We'll advertise it for you. We'll start advertising that one now because we know there is no topic. So Tara can be all over that.
All right, I'll give you the most recent question just to really.
Most recent, fire away.
Hello, doctor. My P4 is always between 2 and 3 when I'm on my menses. P4 day is 21 normal. Will my embryo fail to implant if my progesterone are normally around 2 to 3? No other issues with me.
So I need to know your units. In our units, we are looking for 50 to 100 or 40 to 100. In the more traditional units, you're looking for around 20. That's the US units. I don't know which units you're using, which are 2 or 3. Give me one more.
Okay. Currently on Vizan for endometriosis,
Yeah.
and it has a lot of side effects. I'm 28. My doctor has advised I don't get the vaccine because my medication also puts me at a high risk of blood clots. Opinion.
Pfizer and Moderna do not put you at a higher risk of blood clots, and Vizan does not put you at a higher risk of blood clots. So whoever told you that isn't giving you the right information. So you're fine. If you're on estrogen, you're at a higher risk of blood clots, but Vizan is progesterone. So that doesn't put you at a higher risk of blood clots.
What days of my cycle that I should do LH, E2, and P4? What are the purposes? I'm on cycle monitoring.
So we want to get a picture of what your cycle is like so we know what to do for you, where your eggs are growing, how many, how good is the quality of the egg, by analyzing those various factors. So E2 and LH you kind of do at the start. So we normally do day 3, 8, 10, 12. And then sometimes more like day 14, 16 if you're not growing an egg. Progesterone, day 23, just one time. That's it. You got to eat, man. Let's call it quits.
Whatever you want.
Is there more? Loads more? We could go on. Okay, guys. We could go on forever, but I got to call it quits and attend to a million other things that I have to do still this evening. So thank you for joining us on Fertility Fact or Fiction. Remember that next week there is no paper. This week it was this one, donor oocytes. So next week there will be no paper, and we will be more than happy to take as many questions as we can for another hour and 15 minutes. Tarek will start promoting it now or tomorrow, and that way everyone will know. Let's try and get the biggest show we can, and we'll see you then. So have a great night, stay safe, and for God's sakes, please don't listen to crazy people with all their crazy ideas. There is no impact of the COVID vaccine on your menstrual cycle or somebody else's menstrual cycle or on your ability to get pregnant or anything like that. Get vaccinated. This virus needs to go before it mutates into yet something else, and then all of this keeps going on forever and ever and ever. So get vaccinated, get rid of the virus. Please, I beg you, do the right thing. Have a good night, guys. Take care.